Hello, and welcome to Rolling Out's Health IQ. I am your host, Portia Monique, and today we have a very special guest in honor of Breast Cancer Awareness Month, Dr. Daphne Taylor. She is a hematologist and oncologist. Welcome to the show, Dr. Taylor.
Thank you for having me.
Absolutely. So I want to get started. I want to jump right in, right? So tell us, what exactly is a hematologist and an oncologist, and what do you guys do?
Okay, that's an excellent question. So hematology and oncology is a subspecialty of internal medicine. So someone that might be your PCP, but what I've decided to specialize in is hematology, which is blood disorders and blood diseases. Some you may be familiar with, like sickle cell or different types of leukemias, or oncology, which is the study of cancer. So that would be more your breast cancer, your colon cancer, your kidney cancer, etc.
Okay, and since October is Breast Cancer Awareness Month, let's talk about that. Let's kind of get into the ABCs of what breast cancer is and why does it affect so many African American females?
So I just want to kind of start out with the general statistics. In 2017, the overall rate of new diagnoses per 100,000 people was 125.1. In white women, it's 125.8, and Black women, 121.3. So you see that there's not much of a difference in diagnosis. But when you go and look at mortality, which is the rate of death, in white women, it's 19.3 per 100,000. And in Black women, it's 26.7. So you see that there's a much wider gap in mortality where there's not much of a gap in diagnosis. Black women tend to be diagnosed at a later stage. They tend to have more aggressive cancers than when white women are diagnosed. Some of that has to do with access to care and other disparities in medicine.
So how do we change that? How do we change the narrative going forward for especially African American women to lower that mortality rate?
I think one thing that I would definitely suggest to African American women overall is, since we try to take care of everyone else, we need to start focusing on ourselves. You cannot give from an empty cup. And that's in all things and in all ways, not just breast cancer. So I would want my fellow Black women to really focus on your personal health. You can't help anybody else if you're not healthy. Please take off the Superwoman cape. You don't have to be Superwoman. But regarding breast health, I would say really get to know your breasts, especially for younger women, knowing your breasts in different parts of your cycle, because your breast, the feelings of your breast will change. So if you start to know your breast and doing a breast exam in the shower, that'll help you know if something is different, so you can bring that to the attention of your physician. And if they blow you off, keep advocating for yourself and say, no, something is wrong. I want to get it checked out. Another thing that we all need to do is know our family history. Write down the family history. I know sometimes Mama, Mima, Nana doesn't want to talk about what's happened in the past, but you need to know, because if you see that there's a pattern of breast cancer, ovarian cancer, stomach cancer, then it may be a genetic issue. That you need genetic testing so that we can be aggressive on what we do before you even develop the cancer, if there's a pattern. So I would say know your history.
I think that's an excellent point. And sometimes we just don't ask the question. I don't know if we don't want to know, if there's a fear of knowing, or if sometimes our parents don't know. But I think we should definitely start to ask those questions more, right? What are some of the signs? So let's take a 20 to 30-year-old. What should they be looking for, and or what signs should they look out for to kind of prepare themselves for checking themselves for breast cancer?
Sometimes you may feel a lump. That's the most classic sign. You don't always feel a lump depending on where the tumor could be in the breast, but things that should raise a red flag would be if the skin of your breast starts to look like an orange. The medical term is peau d'orange, but it looks like an orange skin. So like the thickness, it feels, really thick. It starts to look like an orange. You need to go be seen. Yes, ma'am.
When you say, what was that again?
The clinical term is peau d'orange, which is French, I believe, but it basically, your skin starts to look like an orange skin. The skin of your breast will start to look.
Is it both? What is it?
It can be a little bit of both. It just depends on where it is. It can involve the nipple. Another thing that you're going to want to look for is nipple retraction. Some
Hmm.
women do have nipples that are inverted naturally, but if yours are not and they suddenly invert, you need to go get screened. You need to go get a mammogram. If
Mhm.
you're noticing a bloody nipple discharge, you need to go get a mammogram. If your skin looks red and inflamed and you try antibiotics and it doesn't work, you need to go get a mammogram because that is inflammatory breast cancer, which is very, very aggressive.
Hmm. Okay, so I asked for 20 and 30-year-olds, but I imagine that that is across the board for all women. How early should we start our own self-examinations?
I think you should start in your 20s, just so you get to know your breasts, kind of know how they feel. So it'll be easier for you to pick up if something is wrong. At age 40, we start doing screening mammograms, which you should have done every year. Now, there is a caveat that goes back to knowing your history.
Mhm.
Now, if you have a history of breast cancer in your family, and say your mother or your sister or first degree relative, which is like your mother, sister, dad, someone like that, say your mom had breast cancer, she was diagnosed at 35. We're going to want to start screening you 10 years before your mother was diagnosed. So
10 years before. Okay, that's new for me. I never heard that. Okay.
yes, ma'am. So you're going to want to, that's the good part about knowing your history. So we know when to start screening you. But if you're just kind of average woman, yes, a relative may have had breast cancer, but they were diagnosed at age 70, it's a little bit different than if a relative was diagnosed younger than 45. So it's good to know your history.
So let's get into the different types of breast cancer. So thank you for letting us know that. Some of that stuff I had never heard before. And so you see my facial expression. I'm just like, okay. But that's definitely some great information, right? So let's get into the different types of breast cancer. What are they and how do you treat them?
Okay. So it can get a little bit complicated. I'm going to try to keep it relatively basic.
Okay.
So one way we look at breast cancer is it only in one spot or has it spread? And by spread, I mean spread within the breast. So if it's only in one spot, we call it DCIS, meaning ductal carcinoma in situ. In situ meaning in one place. Or it can be an invasive ductal carcinoma, meaning it's spread throughout the duct in the breast.
Mm-hmm.
So once you know, there's also invasive lobular carcinoma as well. We talked about inflammatory breast cancer, but I'm going to kind of just stick with the most common types of breast cancer. So when you get diagnosed with a breast cancer, you're going to have a type of doctor called a pathologist look at it under a microscope. And they're going to be looking for several things. They're going to be looking for the type of breast cancer it is, and they're going to be looking for hormone receptors and like estrogen and progesterone. And they'll be looking for overexpression of a protein called HER2.
Mm.
So you can have multiple combinations of the hormone receptors, estrogen and progesterone, and HER2. Sometimes women can have estrogen and progesterone positive, HER2 negative.
Mm-hmm.
They can have estrogen, progesterone negative, HER2 positive. They can have triple negative, which is where the hormone receptors are negative and HER2 is negative. Or they can have triple positive, where the hormone receptors are positive and the HER2 is negative.
Mm-hmm.
So I'm going to kind of split it up between HER2 and the hormone receptors.
Okay.
So when you're looking at a cancer that is hormone receptor positive, meaning estrogen or progesterone, that means that that tumor is fed by those hormones. So
Okay.
what we want to do is take away those hormones so that the tumor doesn't have the food that it wants.
Mm-hmm.
So in a way, we put you in menopause if you're premenopausal. So you would take, if you're premenopausal, you would take tamoxifen. If you're postmenopausal, you would take something we call aromatase inhibitors, but that's just another hormonal drug to take away the food that the tumor wants and
Mm-hmm.
needs to live and to keep growing.
Okay.
So that's that. If you are HER2 positive, we have special drugs. So HER2 is a protein that's on the outside of the tumor cell.
Mm-hmm.
And we have a medication that targets that protein to stop the tumor from growing. The main one is called Herceptin. That's kind of the one that most people know.
Okay.
So we use that if you are HER2 positive.
Mm-hmm.
Now, if you are triple negative, meaning there are no hormone receptors to target, there's no HER2 protein to target, then we have to go with chemotherapy. 10 to 15% of breast cancers are triple negative. Triple negative is one of the most aggressive and hardest to treat. They frequently come back despite being sensitive to chemotherapy. Unfortunately, Black women are twice as likely to have triple negative breast cancer as white women. So chemotherapy and radiation are usually a big part of triple negative breast cancer. You also use radiation depending upon the stage
Mm-hmm.
with hormone receptor positive breast cancer. So another thing we need to talk about when looking at breast cancer is how do we figure out the stage?
Right.
So there are 4 stages in cancer. So we, as oncologists, we use a special staging system. It's called like T as in Tom, N as in Nancy, M as in Mary. So the T talks about the tumor. And how we grade that is based on the size of the tumor. We have to know the size of the tumor.
Mm-hmm.
The N is for lymph nodes. So there are lymph nodes all over your body. And sometimes women will also feel lymph nodes under their arm.
Mm-hmm.
So when they do biopsies, they'll also sample some lymph nodes to see if some of the cancer has traveled out into the lymph nodes. And the M is for metastasis, meaning the cancer is somewhere it didn't start. So a cancer that's started in the breast, has it traveled to the bone? That is a metastasis. Has it traveled to the liver? That's a metastasis. So cancer, the breast cancer is not where in a different organ from where it started.
Mm-hmm.
So putting all of that knowledge together and those criteria together, we come up with a patient stage.
Mm-hmm.
In my personal experience, unfortunately, I'm seeing much younger Black women with stage 4 cancer. Much younger Black women. Two patients that were very special to me. One passed at 42, one passed at 36. And much like the Black maternal mortality rate, it doesn't matter your socioeconomic class.
Mm-hmm.
One of those patients was another physician.
Mm.
The other patient had a lower socioeconomic status. So it didn't matter. Unfortunately, the outcome was the same.
Right. Oh.
So breast cancer is kind of like the honey badger. It doesn't care.
You are sharing a wealth of knowledge, and we definitely appreciate you for that. How do women prevent it? Well, I know they can't prevent it, but how do they get care much sooner? Is it we just have to make them aware of it? What would you suggest?
There are multiple issues at play. There is unfortunately racism in healthcare. Women are not listened to. Women have to advocate aggressively for themselves to say, hey, something's wrong. No, I know my body. Hey, something is wrong.
Mm-hmm.
I think, once again, as Black women, we need to just really listen to our bodies, know our bodies, and not just put something off if you know it's wrong. Please go get checked out. This is not just for breast cancer. Please go get checked out and don't wait and don't put it off. I know it can be scary, but if we try to get to it early and we catch it earlier, the outcomes are much better than if it's further down the road.
Mm-hmm.
But some things that make you higher risk are not having children. If you do have children, not breastfeeding. Obesity is a risk factor, which runs rampant in the Black community. But that's a whole nother discussion, and how they do BMI, that's a whole discussion for another day, because that has some issues as well. Those women who've gone through menopause on hormonal replacement therapy, who are taking hormones to kind of make menopause a little more tolerable, that puts you at higher risk. I think one of the best things for Black women is to learn how to do the breast exam for themselves. learn their bodies, and get their mammograms. Also knowing your family history so you can figure out if you are higher risk. I
Mhm.
know access to care is a big, big issue,
Mhm.
a nationwide issue, which I also think is a problem. So even if you did all of these things and tried, if you can't get to a mammogram or you can't afford it or you're uninsured or underinsured, we're still kind of in the
Right.
same space. So those are my biggest recommendations is knowing your body, knowing your family history, and if you do have the means, seeking help.
Taylor, I want to thank you for stopping by Rolling Out Stars Health IQ. Um, where can we get more information?
Some of my favorite websites are cancer.org. They have a really good basic outline of all different types of cancer. I think it's a good place for people to start.
Mhm. Mhm. Okay. And where can we follow you and make sure that we're staying up to date with some of the things that you have going on, social media wise, website wise, all of that?
I I am not really online. I
Well,
have started.
and we can
Um,
understand.
I'm not really online, but I do have a Twitter. It's relatively inactive at Heme, HEME Onyx ONYX
Mhm.
at Twitter. There may be some things coming down the pipeline in the future. Right now, I'm just here to really take care of my patients and try to get the word out and educate my patients on the things that they need to do and teaching them when they do have cancer what they have.
We appreciate you, Dr. Taylor. Thank you so much. And thank you all for stopping by Rolling Out Health IQ as well. I'm your host, Portia Monique, and please follow us for the next episode of Rolling Out Health IQ. Take care, guys.